if I can.
Yeah, for Teams.
Oh, yeah. Yeah. So I'm recording it because what I'm going to try and do is just post it. Normally what I do is I can download this recording and then I will upload it as an announcement so that those of you that are still in the lab or whatever's going on, there's a couple of people that obviously are not part of Pharm's, so I can sort of make sure everybody gets this material, okay? All right, so chapter 39. These are the drugs that are more we talked about the basic bugs, your gram-positives and your gram-positives. These are your multi-drug resistant type of bugs. These are your bad boys. You know, when you're looking at MRSA and ESBL and VRE and all of these terms that we bandy around, but basically what it's saying is these bugs are resistant to a lot of antibiotics that have been tried, okay? They've thrown those ones at them, nothing works. So now we have to go to more of the big guns. And when I said bactericidal, does anybody remember that means that's the killers? Right, those are your killers, right? So these are potent antibiotics. So these are your things like gentamicin and tobramycin. That's what these are, your aminoglycosides. And the thing is, these are pretty potent, and they're potent to us as well. They can cause things like otoxicity, which is hearing loss, and also nephrotoxicity as well. So very potent to the kidneys, okay? So there's certain things we have to make sure with our patients before we give them. One of them is, any idea what it could be? We've got to make sure that their kidneys function well, right? That they've got good BUN and good creatinine and all of those things before we even give some of these drugs. So we're going to check their renal function. The other thing as well, these are the types of drugs that we do these levels on. Remember I said there's some that have the therapeutic index. These also have a thing called minimum inhibitory concentration. And basically what it's saying is when we do a sensitivity in culture, has anybody ever seen what that looks like, the result? Mm-hmm. Have you seen that? And it will have a little S, and S means sensitive, and R will mean resistant by the name of the drug. So they'll have like a urine culture, and it will show what bug shows up, like Enterococcus. And then below it, and I don't have an example to show you today, but I'll try and see if I can find one, but basically what it will show is underneath what the bug is resistant to, so we don't want to use that, and also what the bug is sensitive to. And it will say at the side MIC, and what that means is we need to give a certain amount of that drug for it to actually work. But we don't want to do too much and we don't want to do too little. MIC. That's on page 611. It says here the MIC for any antibiotic is a measure of the lowest concentration of drug needed to kill a certain amount of bacteria. Okay, so that's all that MIC means. It's just I want you to be aware of some of these terms in case they come up. That's all. Okay. So these types of medications, gentamicin, tobramycin, these are your IV medications, okay? And you just all had a go at citing IVs, didn't you? Putting an IV in. So now you know that you want to make sure that you get a good IV, that it has a good blood return, because these meds are pretty toxic, yeah? Not just nephrotoxic or, ototoxic or nephrotoxic, but also can be very caustic to the vein as well. We do tend to check not necessarily the peak, but we will certainly check the trough. So peak and trough with a lot of these meds needs to be done. And one of the things, and I want to say this has been on an exam or something, but the trough level for gentamicin, I'm on page 611. The trough level A trough level above 2 micrograms per mil with gentamicin is a risk for damage to the kidneys and damage to the ears. And I'm talking hearing loss, all right, with these types of patients. So we do need to be really, really careful with these patients. And it says it several times on page 611. I want you to be aware, and I mentioned it to a couple of students, but this is what I want to bring out. You might notice that we give several different antibiotics at once to a patient, not just one. There's a reason behind that. What we do is like a 1-2 punch. So one of these antibiotics basically knocks a hole in the bacterial wall, and the other one then can come behind it and kill it, okay? So right at the bottom here, it talks about a synergistic effect. So we may give two. So it says aminoglycosides like gentamicin, which is what this is often given with one of these beta-lactam medications. And what we do is we give this beta-lactam first, like the penicillin. We knock a hole into the bacteria, and then the bactericidal medication, the killer med, can come in and blow it up.
And that would be why it's a more complicated medicine, because it's a two-stepper instead of like...
Right. So I just want you to understand how that effect works, okay? That's why people get pretty sick, when we give all these antibiotics and things, right? Makes sense, because bear in mind, when you're killing all this bacteria, you've got the byproducts of all of that bacteria that the body has to get rid of, right? So there's a lot to it. All right. Just to give you some idea of the serious gram-negative infections, we're looking at things like Pseudomonas. That's when you see in a wound that green-looking gunk, if anybody's ever seen that. Pseudomonas is one of them. Proteus, Klebsiella, all of those types of things are your gram-negative, horrible infections. And then, of course, we use them for the others, the gram-positive, like we said, Enterococcus, Staph, and strep as well, okay? By the way, bacterial endocarditis usually is as a result of a streptococcus infection of some description. So it might start out as a strep infection and end up as endocarditis, which could be really serious for the patient. Okay. So I think I've basically told you about aminoglycosides. And just bear in mind, it affects cranial nerve 8, which is the ear. Has anybody, when you've seen the picture of the cranial nerves, I tend to use that picture where it's got the different cranial nerves and you make a face out of it. Yeah. You know what I'm talking about? That one's really helpful because when you think cranial nerve 8, that's the actual ear on that picture. Some of you might not know what I'm talking about, but I seem to have...
I've seen it on one of those like...
You've seen it? I thought I had it on one of mine. It must have been in 1640 in the next class. If you don't worry about it too much, you'll see it eventually. Let's see. So we talked about gentamicin, tobramycin. By the way, gentamicin comes in IV. It also comes topical, and we also use it for eye drops as well. But be aware that it can have the same effect even if it's not IV, right? It can still cause that ototoxic issue and nephrotoxicity. One of the things I want you to be aware of is neomycin. And the reason I just want you to be aware of it, this is a medication that gets used as a bladder irrigation. And remember I talked a little bit about you'll have the bladder that will get irritated for certain conditions, or it may have cystitis there and it will need irrigation. So bear in mind, like I said, intake and output, that's a num-sum game because you're going to irrigate the bladder and that's going to come back out again. Does that make sense?
So when you give this, it's not counted as intake because it's coming back out.
It's going to, if it's an irrigation, like it talks about a bladder irrigation, it's irrigating the bladder, all right? It's washing it, cleaning it, coming back out again. That's the goal, all right? All right, quinolones. Is quinolones up here? Let me see. Yes, it is. Alfloxins. What do you see up there that is a floxin? Ciprofloxacin. There you go. Great drug. Quinolones. That's on page 614. So quinolones are great for gram-negative. So it's your bad bugs. I mean, they're all bad bugs, but I'm talking like Pseudomonas, those types of things, all right? And it mentions some of the few right here: Pseudomonas, Pneumococcus, Staph aureus, all of those bad boys. The main one that you're going to hear about is ciprofloxacin right here. And unfortunately, it created resistance because it was so good at what it did that the bugs then started to build up resistance. And so we have another great one, levofloxacin, all right? Levaquin and Avalox. By the way, Levaquin is IV a lot of the time. It's a great drug that's used. We tend to use it a lot. But what I want you to bear in mind is a couple of things regarding these floxins, and this is what you need to know. There's a couple of side effects with floxins. One of them, it mentions in the adverse effect. It's a cardiac effect, and it affects in the PQRST, in that it will affect what is called a QT interval. It will make it prolonged. So basically, it has a negative effect on the heart, right? So it could cause some arrhythmias in the heart. QT interval, you might see that come up. The other thing I want you to be aware of is at the top of page 615, and this does happen, tendon rupture. Yep, the Achilles heel. Some patients will rupture that tendon as a result of ciprofloxacin or levofloxacin. So any of these quinolones, that is a big risk with them. They're great drugs. They work really, really well. But anyway, that's another thing to be aware of. Of course, it says here as well, it has some other issues, seizures, exacerbation of myasthenia gravis. Seems an interesting thing there that causes it. So, but I do want you to be aware of that, about the tendon rupture. That is a really big thing. And what we tend to do is we look at it and say, it's a great drug. It works really well. So we have to look at the risk versus benefit. And most of the time, we're going to go ahead and use it because it's a really good medication.
Right, if you got a big fatty infection, you got to have a big fatty antibiotic. What page are we on?
Yeah, 615. And I'm recording it for you guys.
Oh, okay.
So what I'm going to do is I will download this and upload it over the weekend for you guys. I'll put it in the announcements, as I say, so you have it. All right. And of course, there's lots of things that interact: magnesium, calcium, antacid, zinc, all sorts of things interact with ciprofloxacin. So please be aware of that. But the biggest thing I really wanted to bring out with the ciprofloxacin, with the quinolones, is this ruptured tendon that can occur, okay? And tendinitis as well. But Levaquin is the one that you're going to see used. It's used for pneumonia. Oh, by the way, ciprofloxacin is used for anthrax. Yeah.
That was on one of my EAPs.
Yeah. Inhalation post-exposure anthrax. We don't see that a lot, I have to say, but that's one of the things that gets used. So I do want you to be aware of that. Okay. And on page 616, it just shows you those several different types, ciprofloxacin and Levaquin. The nice thing about Levaquin is you only need to give it once a day. So that's why it's a handy type of medication, just like your zithromycin, right? It's your once a day type of dosing. All right, let's see. What else do I want to mention about this? Clindamycin. So now we get into the ones that don't really fit in any category, but they're important drugs for you to just bear in mind. Clindamycin, is it up there? Clindamycin? No. Okay. Clindamycin is one of those, it can be either or, it can be bactericidal, so it can be a killer med, or it can inhibit bacterial growth, either or, okay? But it's great for bone infections. It's a good, solid drug for types of bone infections and really serious skin and soft tissue infections, clindamycin. I think that's also one of the ones that I see used for acne as well. Yeah? Mm-hmm.
I think that was on.
Yeah.
I know the bone infection.
Well, and bear this in mind, when you see acne, a lot of it is they've got all this clogged area, right? So the bacteria is working on an anaerobic type of mechanism. So clindamycin is great for clearing up acne. It's a strong drug though. Adverse effects, of course, things like C. diff. So we're going to make sure we give them what? Anyone remember? Yes, thank you. Well done. Probiotics. You got it. Okay.
Does it have that same effect when they're taking it for acne?
I would. My guidelines are, if you're on an antibiotic, you need a probiotic. Whether it's yogurt, whether it's kefir, whether it's kimchi, anything that's fermented. What's the other one that's kombucha is another one, right? They're fermented products that you can use, but probiotics are a really wise idea when you're taking antibiotics. Says me who's on antibiotics, but I take live yogurt, so there we go. I don't think, all right, next one down I want to talk about on page 618, Flagyl or metronidazole, which I want to say, yes, there it is on your list. So metronidazole is a really good drug that's used for protozoa type of infections, anaerobic organisms. So things like trichomonas and bacterial vaginitis, those are the types of things that you're going to see Flagyl being used for. It used to be used for C. diff, but now we use vancomycin. But anyway, any of those sort of protozoa type of things, I would say bacterial vaginitis and trichomonas. All right, very, very useful for those. Again, remember I talked about not taking alcohol because of that diphosphorus type of reaction. They can get very nauseated, start throwing up, shaking, sweating, all sorts of bad side effects. Flagyl, that's one of the biggies with Flagyl. Don't let your patient drink alcohol with Flagyl, even 3 days afterwards. In fact, it talks about it that right there. They have to avoid alcohol 24 hours before therapy and at least 36 hours after therapy. Okay? It does go through the liver. Next one I want to mention to you is, and it's on there as well, nitrofurantoin, macrodantin. What do you think that's useful for? Anyone ever had one? UTI, yes, urinary tract infection. So this is a great drug for that. Okay, it's very, very good for those. It is oral. Let's see, what else do I want to? trying to see if there's any big deal stuff. I mean, yes, it has all the usual issues, GI discomfort and everything under the sun that all of the rest of them have. Okay. I think that's really it, but just bear that in mind. All right, vancomycin. Vancomycin up there? Should be, I hope so. Yeah. Yeah, vancomycin. So on page 619, vancomycin. This is a bactericidal medication, so it's a killer med. Gosh, we use it for all sorts of things. It's been around forever. We use it for C. diff. Oral vancomycin rather for C. diff. We also use IV vancomycin for things like, let's see. Let me have a look and see what types of things we use it for. It doesn't tell me. A lot of them. What do you think the issues are with vancomycin? Anybody know? Anybody ever infused vancomycin or seen it infused? No? Red man syndrome.
Yeah, I read that.
Okay.
That was on my list.
It's a real thing. It is a real thing. You start vancomycin very, very slowly. Okay. It can cause otoxicity again and nephroticity. I can't pronounce it. But basically damage to the kidneys or hearing loss. We do measure it. Become toxic very easily, but you have to start that IV slowly and you will literally see somebody turn red. Okay. It can also cause a lot of other skin type. It says it's not harmful, red man syndrome. It causes flushing of the skin. Sometimes you have to pre-med that patient as well with all this type of thing. Care with infusing it too fast because you could cause hypotension. All right, but red man syndrome is the big thing to remember with this. Okay. And again, you're going to do peak and troughs on this particular situation as well with this particular drug. Okay. You infuse it at least over 60 minutes. You're not going to do it any faster than that. So some of the things, the nursing assessment stuff, right? We're going to assess for any other super infection like we talked about. Anybody give me a clue what I meant by super infection?
Yeast infection
Yeah.
resulting in the dose of the name.
There you go. That's a great example. I don't know if these are out. Heaps. Oh, they are. Okay, they're all coming in.
Sorry. Are we gonna be able to do like that stuff on each other?
What stuff?
Like draw blood and
Yeah, I'm going to do that again next week.
No, I'm saying, are we gonna be able to do it on each other?
No. Not here, you can't.
When you go home.
If you go home, have fun with it, but not here. Unfortunately. All right. Please be aware of things like antibiotic resistance, like we talked about, okay? Aminoglycosides, like I said, aminoglycosides like your gentamicin, all of those types of things. Remember I talked about what types of issues could be created with that. Ototoxicity and nephrotoxicity, okay? Yeah, absolutely. All right, good. All right, metronidazole is what? What's the other name for metronidazole? Flagyl, good job, yeah. When I think flagyl, I always think it has that little whip tail like a protozoa does. That's how I tend to remember it. It's good for trichomonas, so it's good for bacterial vaginitis. And what are you going to tell your patient that they can't do?
Alcohol.
They can't drink alcohol. Good job, guys. You're doing really well. All right. So I do want you guys to look at chapter 39 regarding some of these assessment pieces that we just talked about. There's a nice little case study here with a guy who's 45 and has vancomycin. It says they gave him vancomycin. He actually started having the issue 2 days later. What do you think he was having? Look at what he was having. He was feeling hot in his face and neck and itching in those same areas, and his face and neck is flushed. What do you think? Red man syndrome. Okay.
So when I tried to go on the Evolve website, so when I did those case studies, you know, so because it gives you the answers to make sure you're doing it right, it won't show up.
Huh.
Like you can click on it, but it doesn't do anything.
I don't know. I'm not sure why that is. That's strange.
No, red man's, it's not instantaneous, or not instantaneous.
Usually
It's not
when I've usually seen red man syndrome, you know, you start the infusion slowly, and if someone's you're watching. That's why you start it slow, because you're watching for that. You know, but it's like they're saying, it's not that it's bothersome, but you can pre-med somebody and still give vancomycin. So meaning, when I say pre-med, you might have to give them Benadryl, Decadron, something like that. You may need to give a pre-med of that before you give this particular medication. Okay. So we're going to give lots of fluids with our patient, all right? Because we're going to take care of their kidneys, aren't we? Make sure the patient takes the whole course, because what happens when they don't take the whole course? Yeah, antibiotic resistance, exactly. What did I say about my quinolones? So my things like ciprofloxacin, what's the big issue with those?
QT prolongation.
QT, yeah, prolongation, and
The tendon rupture, something.
yeah, tendon rupture.
There.
You got it. You got it. Levaquin is the other one as well. So levofloxacin and ciprofloxacin. Okay. So please, please, please look at some of these items on 622 and 623, because actually in 623 there's a really nice little cheat sheet. I like these patient teaching little boxes that just sort of break down the high points, the key points of what you need to know. Quinolones, by the way, photosensitivity is another piece of it. Okay. All right. Let's see. What about this question here? While assessing a woman who's receiving quinolone therapy for pneumonia, the nurse notes the patient has a history of heart problems. The nurse will monitor for which potential cardiac effect of quinolone therapy. Question 1. What is it? D. Good job. Prolonged QT interval. Yep, you got it. You got it. Okay. All right. Antivirals. Antiviral medications. So one of the things I want you to be aware of is that with viruses, they have to get into their host in order to replicate. This is where I say it's like aliens, because you know they have to actually get in there before they start replicating and bursting forth and doing all the stuff they do. Okay, when they're out there, not a problem. Once they get inside us, that's when it starts to be a problem. That's when they start replicating. And it says here, viruses can only replicate inside the cells of their host. Okay, so that's important for us to know. I just want you to be aware of it. Various different routes. Inhalation is one of them, of course. Ingestion, transplantly, mother to infant, and inoculation. So like something like a vector, like a mosquito, all right? So that would be one way. I do want you to understand a little bit. Let me see what I want to just talk to you a tiny bit about. Let me see up here. We're going to talk about TB in a minute, but I'm just looking to see if there's anything else I want to talk about. Okay. I want to go down to page 628, down the bottom. I want you to be aware of the fact, like I said the other day, viruses, antiviral drugs can kill or suppress, but you're never going to completely get rid of the virus. So let me give you an example. If I have a patient who's got a history of Epstein-Barr virus or mononucleosis or something like that, or mono, when I draw their labs, it's going to show that they still have an antigen to that. Same with the coronavirus, things of that nature, okay? You're always going to see that there. It's lower, they're not acute, but you're always going to see that viral load there to an extent. Does that make sense? So when I draw their blood and I look at certain aspects to what I'm looking at, I'm either going to see an infection that is immediate, meaning it's happening right now, or I'm going to see an infection that was there sometime maybe 20 years ago, but it's still going to show up that they've been positive for that particular infection, like Epstein-Barr. So it's just something to bear in mind, because it can still have an effect on the patient, right? Even though they don't actually have any symptoms of it anymore. All right, so let's look at a couple of these particular ones. Herpes simplex virus. So we've got various different types of herpes simplex, don't we? We have herpes simplex 1, which is usually oral. We have herpes simplex 2, which is genital herpes. We have herpes simplex 3, which is chickenpox and shingles, or herpes zoster. We've got herpes simplex 4, herpes virus 4, which is Epstein-Barr. And then we also have 5, herpes virus 5, and that's cytomegalovirus. By the way, a lot of healthcare workers have cytomegalovirus and don't even know it. Just to let you know. And there's more. There's herpes virus 8, which is Kaposi's. We tend to see that more in our HIV/AIDS patient, okay? So let's just look at herpes 1, which is the outbreak on here, right? On the oral, and 2 as well. So herpes 1, what are we going to treat it with? We're going to treat it, well, actually, and 3. So shingles, all of them, they're going to be treated the same way. Acyclovir is going to be used for these types of patients, or a form of that. Valcyclovir is another one that can be used. It can be oral, or it can be a cream, okay? So bear that in mind. There's a vaccine, by the way, for your shingles patient that we offer at the age of 50 and above, the Zostavax, that can be given if they want it. And a lot of time, if you've had chickenpox, then people think that they have an immunity to shingles, but sometimes what will happen, unfortunately, is if you've had chickenpox, then you may end up, remember that virus is still there, so you may have something that's incredibly stressful, and bam, you end up with shingles. So, okay, so it's something to bear in mind. What else do I want to do? Oh yeah, hepatitis. So we've got different types of hepatitis, don't we? We have Hep B, we have Hep A, we have Hep C. Hep B occurs through blood and body exposure, and it's preventable by a vaccine, which we've all had, right? We've all had the Hep B vaccine, thank goodness. But there are certain medications as well, antiviral, and I want to say that ribavirin, I'm trying to see where that is in all of this. Oh, ribavirin, here we are. That's actually ribavirin, by the way, I'm sorry.
Oh, it was a lot of the handwriting.
It's mine,
Threw me off. I was like,
So it's RIB, ribavirin. In your books, just so you know, in your books, there's a little table, 40.1, and it's right in there, ribavirin. And the reason I bring that out is because, as I say, I've seen it on exams and things. It's sort of just one of those many, many antiviral medications that are, this one is not used for HIV. It's a non-HIV medication, along with things like acyclovir. All right. Where do I want to go? And then below this, if you look at table 40.3, it shows you all the different types of HIV drugs, of which we have a lot to choose from now, right? And what we're trying to do, we're trying to suppress that virus. We're trying to suppress that virus and make sure that our CD4 count stays up. As the CD4 count drops, that's an indicator that the patient is more and more immunosuppressed. Okay, we don't want that. So all of these antiviral drugs are trying to help that patient maintain their immunity. All right. So on page 632, I just want to show you a few of these antiviral drugs. By the way, amantadine, right at the top there, we used to use it as a flu medication. We don't use it anymore. We use things like Tamiflu, Ostellav, I can't ever pronounce that. Somebody help me out.
I can't pronounce that.
Tamivir, basically, and Zanamivir. So those are the ones that we use for flu A and flu B, not amantadine anymore. But by the way, amantadine gets used a lot, funny enough, for TBI patients. Helps wake them up. Yeah. But anyway, let's look at some of these other ones. Acyclovir, like I just said. Zovirax is used. In fact, I just had a patient yesterday that was it yesterday, the other day, I ordered this for. She had a herpes simplex 1 and she was calling up and saying, I need it desperately. So I actually did this. I did 400 milligrams 5 times a day for 5 days for her. So we use it, right? We use it well, and that helps suppress it. So acyclovir is one of the ones that can be used. And as I say, you can use it. The nice thing about valcyclovir, which is a similar one, is you don't actually have to give it as many times as you do acyclovir. That's what the difference is. Less frequent dosing, whereas acyclovir, to really suppress that virus, you might need to do it 5 times a day. Gangcyclovir, I used to use this a lot for my cytomegalovirus patients, which are my leukemics, which unfortunately become immunosuppressed and then anything gets them, okay? So then I would just want you to look at the, for the Tamiflu and the Relanza. Bear in mind what we talked about the other day. You have to begin this treatment within 2 days of symptom onset. There's another one as well, Zofluza. So it's oral, just a one-time dose. So there's several different ones that we can use. And then this ribavirin right down the bottom. For some reason, Hesse loves this one. I'm not sure what that's about. I don't know why. Ribavirin.
Yeah, that was on my remediation.
Yeah.
I'm not sure. Somebody who writes
likes that one.
somebody who writes the Hesse exams must be on it or know someone who needs it or something. I have no idea. But, you know, to me, of all the antiviral drugs to use, why this one? But it is what it is. So that's really why I just want you to be aware of it, especially because it's really treated. It says for hospitalized infants with RSV. So we're looking at a fairly, narrow group of patients here But please be aware of it. It is tetragenic as well. So it is a risk to the embryo. Again, like many other medications, we have to be careful and tell our patients to use 2 forms of contraception. And you're not going to give this to pregnant women. Okay. All right. Let's see. HIV. I don't think we actually have any HIV medications really that we need to be aware of. Let me see if there's anything I really want to bring out in there. I think predominantly what I want to show you on page 637, look at all these amazing, I mean, we have so many HIV meds.
Thank God.
Isn't that a lot of meds, right? Yeah. But really what we try and do is HAART therapy, which stands for highly active antiretroviral therapy. And really what we're doing is a combination of different types of medications to do what I said. We're trying to suppress that virus as much as we can for as long as we can so that the CD4 count stays up. Okay, that's really what we're trying to do. It talks about it right here. When the CD4 count falls below, and that's part of the T cells, by the way, when that count falls, then the patient is at risk for more opportunistic infections. So that's what we're trying to do. We're trying to prevent that from occurring with these patients.
You draw labs on them a lot.
Oh, yeah. Yeah. Normally they're managed like a HIV clinic, those types of things more, especially because there's so many different meds that, you know, there's the latest and greatest coming out that they can keep an eye on them for. But the biggest thing to bear in mind is this HAART therapy, and it usually includes about 3 different medications. All right, 3 different medications, and all of them work in different ways. But what really happens here, if you look at the top of page 636, what it shows is the HIV getting into that particular cell, replicating, because it has to get into that cell, right, first, before it can cause any damage. So it gets into the T cell, gets in there, and kills the T cell. That's how HIV works. The more T cells it kills, the more the patient's immune system goes down, and that's the problem. So that's what we're trying to prevent. All right. Don't think I need to, I'm looking at my list for you. I think the big ones I just want to mention is 2. AZT, down on the page of 639, zidovudine, or retrovir, which is known as AZT, and that's really the prototype HIV medication. So just be aware of that one. Okay. The big issue with that, it can cause bone marrow suppression. So unfortunately, this medication that we're giving to help the immune system can actually have the negative effect of suppressing bone marrow. So then we have to switch into something else. All right. So I think that's really all I want to, with assessment with our patients, I really think that's pretty much all I want to do with. Ganciclovir is another one that can suppress bone marrow. And as I say, I don't know if things like this come up on your HESI, but I'm just percolating your brain with some of these things. So if it ever comes up, you're like, I think she said something about bone marrow suppression. You know, it might just be one of those things that
Something on the HESI tile about the.
There you go.
That Z one, the racial.
Ganciclovir? No.
The Z one.
AZT?
Yes, I've seen something on my Hesse towel about that.
Ah, well, it does cause bone marrow suppression. That's one of the biggies with it, okay? Let's see. Trying to think if there's any other things. The big things again on page 643, that patient teaching section pretty much just goes in to some of the things I talked about. Obviously, with our patient that has a reduced immune system, we don't want them going out in crowds, do we? We want them to reduce their exposure, those types of things as well. So bear that in mind. All right. Moving swiftly on. Goodness, we've still got 3 more chapters. I told you I needed to get through a lot with you. All right. Chapter 41, TB meds. All right, so TB, it's bacterial, it's not viral, bacterial, and we breathe it in, right? And where does it go? Goes in the lungs, yeah. It goes in the lungs, and it's droplet, isn't it? That's what we're doing here, droplet precautions, which are big droplets, and then we breathe those things in, okay? That's the issue right there. It's a rod-shaped microorganism. It's a bacillus. It's aerobic. Aerobic, so if you don't know anything else, it goes to the lungs. Lungs have air, so we know that this bug needs air, right? Aerobic. So that might help you connect the dots a little bit. It's not anaerobic, it's aerobic. Okay. So that's basically the cycle of what happens. They're coughing it out, we're breathing it in, and around and around and around it goes. Okay, so what are we going to do? First of all, one of the things we can do is a TB test, yeah? PPD, we can check and see what's going on. We normally do it intradermal, don't we? Did some of you do that today? Any of you have a go at doing that? A couple of you?
Mhm.
How'd it go? Okay. We can do the tuberculin skin test and see what's going on there and see if it's positive or not. We're going to hit them with different meds. One of them is right here, isocyanide, right? That's your TB med right there. Normally, and that is your primary anti-TB drug, it's going to be on the Hesse, guys. I promise you. It will be on the Hesse. Normally, you'll start the patient on 4 different drugs. You'll start them on isocyanide, rifampin. What does rifampin do? Somebody told me the other day, one of you did, about the urine. Oh, that was in 1640. Anyone know what color it turns the urine? Orange. Yeah. Yeah. I'm strolling through
Yeah, 647.
647.
41.
I'm sorry, what did you say you sure is gonna be on the Hesse?
Isocyanide.
Oh, okay.
Yep,
That's the one in blue on 647.
Got it written up here. Yep. But normally you don't just have one TB med. They normally start out a combination of about 3 or 4 of them. The other ones involved are rifampin, ethambutol, and PZA. They work in different ways to attack the cell, and that's why we want several of them. Now, rifampin, by the way, will turn not just your urine orange, but all fluids. So tears, saliva, apparently. So that's a teaching point for your patient that they need to know. Okay? But all of these drugs have a different mechanism of action. So as a result of that, they all work together to basically kill that TB bug. That's the whole point. So I want you to be aware of a couple of things on page 648. First of all, I just said isocyanide is the mainline drug along with some of these others. what is it going to do? And this has been on an exam. The major effects of drug therapy include reduction of cough and therefore reduction of infectiousness of the patient. Now, this is why this is important. It will say something like, how long does the patient need to be away from other people, or something along those lines. Usually it's a couple of weeks, okay? Because once that cough is suppressed and they're not coughing, then they're not really infectious. Does that make sense a little bit? It's not that they don't have the infection, they do. It's just that they're not coughing out these droplets anymore and letting other people inhale those droplets. So it says it right here, normally occurs within 2 weeks of the initiation of drug therapy. So it also says with appropriate antibiotic, most cases of TB can be cured, but the patient is going to be on antibiotic therapy for at least 6 months, usually 9, sometimes 12. So bear that in mind as well. This is not a short fix. These patients are on these meds. Usually at that point, they start out, as I say, with 3 or 4, and then a few months in, they knock it down to 2. So this is a lot. They're managed by the health department usually as well. This is one of those infections that has to be reported to the Department of Health. Okay. Something I want you to be aware of, tuberculosis-related injections. So you know about the PPD, you've all had one, right? Mm-hmm. What do you think a positive result is noted? How do you know that you're positive? Are they looking for a lot of redness?
It's right there.
Are they looking for redness or something else?
If it's right.
Induration. So it will be like a hardness, okay? That would be the area that they're really looking for. Not just redness, but what's called induration. And again, that type of thing could be on one of your exams. The other thing I want you to be aware of is people like me. I don't know if I can show it to you. I don't know if I take this off, I might be able to show you. Who's from another country other than me? Do you have one of these? Got a PPD? You got a BCG?
I think so.
You got one? You got your scar?
Oh, yeah.
Yeah, there you go. Do you have your scar? See, we're special. Let me see. What was it? We have a scar.
It's from a vaccine.
Honey, you left when you were 2.
Yeah.
Where was it? Peru? Yeah. Yes.
I can't even live like
You kind of just shut it up.
God, don't
It's
that
just
thing
scar.
tight. Oh, I see it.
Yeah, see? Yeah, wait, let's see your
I didn't
scar.
get my other one.
You have a great scar, right?
Beautiful
scar. It's your scar.
I believe.
Oh, okay.
It's the only thing.
I know I'm being personal here, but
I was the only one.
you know me by now. When has that ever bothered me, right?
I think that people used to get here because I know other people have that scars.
And they're like, whoa, I
Oh,
got
she's got it under now.
That's all right, you do it.
It's there somewhere.
Where is it?
Where's your PPT?
It's closed up next year.
No, they don't. They don't
It's
get it.
It's somewhere down there. I can't see it, but that's okay. But the bottom line is, we from other countries all have what's called BCG. And I don't know if you can see this little mark right here. And that's how you'll tell a lot of us that have actually initiated. And BCG is actually a vaccine against TB. I'm not sure why they don't do it in America. I think because they thought it had been eradicated, but honestly, I'm like, well, why
If they
not
don't
give
pick it
it?
up, then it's not gonna stay around.
Yeah, I don't know why they don't do it. We all got what's called a BCG. It blows up like a little balloon. I don't know if you remember. It comes up like a little bubble and it looks delightful. And then you end up being scarred for life, literally. But it's supposed to protect you against TB. I'm not sure of the efficacy of a BCG. It probably wears off after time, and I think that's one of the things that it says. But it's nice to have a bit of what's the word I want? Immunity, yeah? So even so, most countries, we do get a BCG, just FYI. So, if you want one, just ask. All right. Let's see. Be aware of isocyanide and ethambantul can be used to treat pregnant women. And also rifampin is safe as well. Let's see if there's anything else. Oh, one of the things I really want to mention about isocyanide is that it reduces B vitamins, peroxidine specifically, which I think is B6. Is it? Yeah, B6. Peroxidine is reduced with isocyanide. Now, why is this important? It's important for your young children, by the way. Okay. So you want to make sure that you supplement with B vitamins. And that has been on an exam question as well. So you're going to use supplementation of B vitamins with isocyanide. B6 specifically, peroxidine. And the reason it's important is a lack of B6 can cause like mouth sores and gingival issues and all sorts of things like that, as well as nerve ending issues, mental status changes. So you really want to make sure that patient has B6 along with this, okay? By the way, if you're on a birth control pill, you also need to make sure you take B vitamins as well. It really depletes B vitamins, just FYI. So, let's see. Trying to see if there's anything else. Okay. Isocyanide is going to be on the exam. Another one that I've seen is rifabutin, which is a little bit like rifampin. Rifabutin and rifampin on page 651. Okay. So please, please, please be aware of what I said about both of these can turn your urine orange. It says stool can turn like a red orange, saliva, sputum, everything. So you really need to let your patient know about that, okay? It's one of the biggies. And yeah, isocyanide, like I said, make sure you give B6. Peripheral neuropathy can be a side effect of not having enough B6, along with other things as well. Okay. Let's see. Some of the pieces, the teaching pieces, I would say that is a really big piece when it comes to TB medications. Bear in mind these TB meds, and they normally get somebody from the Department of Health to come out to the family's home, because it may not just be that one person, it may be, several people in the family. These meds have to be taken exactly as ordered, on time. They can't be missed, because remember, they have different mechanism of actions. They're all working in different ways to kill off this bacteria. Okay, that's what's going on here. Some of the things to be concerned about, again, ototoxicity, which is what? Ears, yep. Nephrotoxicity, which is kidneys, yep. Seizures. Let's see what else. Tingling and burning in the extremities, which basically is going to be the effect of what? A reduction in B6. Okay? Take your Bs, that's for sure. The other thing I want you to know about is acid-fast bacilli, AFB. So you might hear that you have to have 3 clear AFBs, sputum tests. So they'll do a sputum test early in the morning on these patients. Normally they have like 3 in a row, 3 mornings. And if they're clear, meaning there's no acid-fast bacilli in them, then that basically means that this patient is cleared either to go home or they're clear in the community. So acid-fast bacilli. It talks about it on page 653, AFB, acid-fast bacilli testing. And let me see if there's something I want to point out. I think that'll do. I think that'll do for that. Bear in mind, like I said about isocyanide, all of the side effects, and the biggie is that B6, peroxidine. You're going to make sure they take that. Making sure women on oral contraceptives don't just stay on one, right? They may have to be switched to another, or they may have to use 2 different forms of birth control. Okay. Actually, oral contraceptives are ineffective with rifampin. Ineffective. Oof. All right. Something for them to be aware of, isn't it?
Somebody showing up, you got me pregnant.
Yeah. Yeah. All right, we're getting there, guys. Chapter 42, antifungals, and 44, and then we're done. All right, but I really wanted you guys to have this information. Is that okay?
Yes.
Okay. All right, antifungals. So that's things like yeast, mold. Basically, we can ingest them. They can grow on our skin. Okay, sorts of things like that. Fungal spores, which we can inhale. Lots of different ways of getting a fungal infection. So some of these basically antifungal drugs, some of them are systemic and some of them, of course, are topical. Systemic meaning, we're going to give them IV or we're going to give them topical. Fungus, very, very difficult to kill. And fungal medications are sort of fairly toxic as well. Okay, so some of them I want to just mention to you. One of them is what's called an antimetabolite. We actually use it in chemotherapy, by the way. It's called 5-FU, and it is used in chemo, and it helps to break down particular fungal infections. So we may use that. I've seen it used as a cream, by the way.
I think that was in one of the EMQs too.
Oh, really? It was about 5-FU, yeah. Grisovolfin, and I don't think it's up there, but that one is used a lot for, say, fungal infections of the nail, things of that nature, and it can be taken orally. And it can cause liver toxicity. What on earth is it?
All I heard was like.
I know.
I'm so hungry,
You
man.
had a whole pepper. I'm like, what's she eating?
She's been crunching on peppers.
I got peppers, chips.
Oh,
I'm
gosh.
hungry now.
She packed the house.
It's what time I usually eat when I get out of school.
Oh. All right, let me give you a few of these medications. Amphotericin B. It's not up there. We call it amphoterrible. Anybody ever been on an oncology floor and worked with patients that have had to have amphotericin at all? Yeah, no. It's a really awful medication, great for fungal infections, but basically when you give it, the patient literally will almost shake off the bed. I mean, you have to pre-med this patient big time in order to give this medication. They will get a skyrocketing fever. You will wrap them in blankets. They will be shaking and their teeth will be chattering. It's a really bad drug. There is another form of it now that's more of a lipid-based called Ambazone. And that's slightly better, but even so, amphotericin B is one of the biggies that treats systemic infections. So I just want you guys to be aware of that. Nystatin, right? We use nystatin to treat all sorts of things like thrush, don't we? Nystatin you can get as a cream, treat many different types of infections. Fluconazole, is fluconazole up there? No? Is it?
Oh, no, it's not.
It's not. Oh, I'm sort of surprised actually. So anyway, fluconazole, that whole genre, ketoconazole, all of those types of meds. But fluconazole basically is used to treat fungal infections. Like if somebody's got an oral fungal infection, you might use something like fluconazole for that. One of the other ones is voriconazole, and that's more for invasive stuff, but also for, say, like toenails. When you see fungal infections of the toenails and things like that. Ketoconazole and itraconazole. So anything with a zole at the end is for fungal infections. You know how we've got these prefixes and suffixes that we tend to be able to clue into and go, okay, I don't exactly know what it is, but if it's got a zole at the end, it's probably for a fungal infection, okay? All right, and then the other one I just want to mention is two more. Grisofolvin is for tinea infections, like ringworm. And this one is on the exam, and I don't think it's up there, interestingly. I've seen this one before.
Where are you reading about?
Terbinafine.
Right here in the selected antifungal drugs.
Oh, yeah. Well, I'm actually reading on page 658, actually, but yes, all of these.
On 660.
But
What's the other one you just said?
terbinafine.
In the middle. Which one did you say for ringworm?
I think it's grisofolvin for tinea infections right down the bottom there. Maybe you have a different book to me?
Okay, I see what you're talking about on 657.
Yeah, at the bottom.
And at the bottom, that indifferent.
Yeah, I'm looking at all the different, 658.
Yeah.
658 is where I am.
Yeah.
The indications, it's a section about indications is what I'm saying.
Okay.
But anyway, terbinafine is what is used for people that have like bad fungal infections in the toenail or in the fingernails. You know, then they've been to the nail salon and they get a fungal infection. Terbinafine is one of the forms that can be used. Okay, but let's have a look at some of these side effects, shall we? Because of course they've all got side effects. Terbinafine, I've seen it on an exam. It's also known as Lamisil. You sure I don't have it up there? I do have it up there. Lamisil, thank you. Lamisil. Antifungal, it can be taken orally or as a cream. Problem is with Lamisil, it can cause hepatic damage. So you've got to check your liver function before you give this medication. Okay. Fluconazole, like I said, oral fluconazole. If somebody has a fungal yeast infection, vaginal yeast infection, we can just do a 1 dose of fluconazole usually orally, or you can actually, there's a vaginal suppository that you can give as well. Okay, so usually just 1 dose is good to treat. Nystatin, obviously that treats all sorts of things from diaper rash to all sorts of stuff, so we've used that before. And then, as I say, terbinafine or Lamisil is important as well. Thank you. Okay. So let me see what I want to say about fluconazole. On page 662, I need you to be aware that when you give this particular medication IV, fluconazole, it has to be protected by the light, from the light. Otherwise, it reduces its stability. You'll normally see it in a brown bag. Okay. And some of the things just to be aware with the patient-centered care, instructing patients that are taking antifungal medications for, vaginal infections. I think it sort of goes without saying, but tell them to abstain from sexual intercourse, otherwise you potentially are going to infect your partner and then get reinfected again. Okay, so, pardon? I can get a baby. There you go. Yeah. Again, fluconazole is one of those ones that can affect the liver. And also be aware that they need to have another form of contraception while taking this med. A couple of other things I want to point out. Fluconazole, if the patient starts complaining of clay-colored stools or really dark urine, that's a ding, ding, ding that there might be some liver function issue going on. All right. So again, just be aware of that. Oh, I'm way past that. I'm recording it though.
Oh, okay, wait.
Antifungals. Okay. Finally, with terbinafine, in this little section in the patient teaching section, remind your patient they may need to be on Lamisil for about 8 weeks, 8 to 10 weeks. It says 10 weeks for toenail, 4 weeks for fingernail. Okay, so there's a lot of pieces in there that potentially could be on an exam, especially fluconazole and Lamisil. Let me just see if there's anything else I want to say. And the sort of thing that comes up on exams, by the way, in the side effects, possible effects, of course, nephrotoxicity, liver toxicity, but it also says under anticoagulants that it could increase the efficacy of anticoagulants. So just if you see that on one of the that might be one of those ding, ding, dings. Oh yeah, I remember her saying something about that. Okay. So, all right, finally, guys, we're on the last chapter. I am doing 44. No. It's 41, 42, and 44. So I just did 42. I'm not doing anti-malarial. Okay. All right, so 44, we're switching gears a little bit. We're going to talk about NSAIDs. NSAIDs. Basically, we're looking at our anti-inflammatories, okay? So what happens, if you see on page 679, when we get inflammation, which is a natural response, it shows you 2 different pathways. We've got what I call the asthma pathway, which is the leukotrienes. So you get some sort of inflammatory reaction. And what happens is it can go down what's called the leukotriene pathway. So leukotrienes are stimulated, and then somebody who has asthma is going to start getting an asthma attack as a result of these leukotrienes being stimulated and increasing in their body. Okay, that's one way. And they're going to get inflammation. So they're going to get bronchospasm, all of those types of things. Or the other way that you can end up with inflammation is down what's called the prostaglandin pathway. And that's looking at things like osteoarthritis. So that's how I sort of differentiate them a little bit. Leukotrienes is more your asthma patient. Prostaglandins is more your sort of osteoarthritis type of patient. And as you can see, there's certain steps that happen. Prostaglandins downregulate to this thing called COX that then that ends up with these prostaglandins causing inflammation in that way. So it's either the leukotrienes or the prostaglandins, one or the other, sometimes both, okay? So what we're going to look at more, not so much the leukotriene pathway, but this other pathway, this prostaglandins. Okay. So what happens is we get this conversion of prostaglandin down to this thing called COX, cyclooxygenase, basically. And that turns into things like vasodilation. It increases things like histamine in the system. It increases edema. And then it increases things like joint pain and all of those things, those inflammatory processes. So what do people do? They take NSAIDs, don't they? NSAIDs, non-steroidal anti-inflammatory drugs, okay? And we have a lot of different ones. One of them right here, it says is aspirin. Aspirin is one of them, yeah? Aspirin is great for certain things in the sense of it's not just good as an NSAID, but what it's also good as is it's got protective qualities against strokes and other heart attacks. So aspirin is sort of in its own little box as opposed to all the rest of them because it's the only one that you can give for somebody who has cardiac disease. You cannot give things like ibuprofen to somebody who's had an MI. It actually can potentially make their life expectancy shorter. Yeah, can give aspirin, not ibuprofen, just FYI. So we're looking at a few of them. Aspirin is one of them, as I said. We've got corticosteroids, but that's off in its own little box as well, okay? So then we develop things like NSAIDs. So what are we looking at? What types of drugs are we looking at? Box 44 tells us what we're looking at. Can anybody tell me any of them? I know you've all used some.
Aspirin, ibuprofen,
Yeah.
Oxy.
Yeah, exactly. Yeah, exactly.
Celebrex. My mom takes Celebrex.
We don't use that so much anymore.
Really?
Mm-mm.
She loves it. She swears by it.
Well, we'll talk about that in a second. Yeah, we don't actually use it that much, funny enough. Yeah, Toradol is another one, exactly. So I won't. Yes, you're right.
Okay, girl.
Good job. So basically, these ones are going to go down either the leukotriene pathway or the prostaglandin pathway, either or. But what they basically do is remember I just said this is an enzyme called COX, they block it. So by blocking that, it reduces that pathway effect and blocks the inflammation. So that's how it works, all right? NSAIDs inhibit COX-1 and 2. There used to be ones that just inhibited COX-2, which was great because it had less side effects. But then they actually found it had more side effects, so they've stopped using it so much. Really, the only NSAID we're going to use for a person who's had an MI or any thromboembolic disorder is aspirin.
And preferably baby aspirin, right?
Baby aspirin, exactly. Yeah. Let's see, we use NSAIDs as well along with opioids, don't we? Sometimes the two are combined, like it will be codeine combined with some of these things.
I had that on my hectic.
Yep, exactly. And the nice thing about it, it says right here, it says NSAIDs are sometimes combined with an opioid. And it says right here, they tend to have an opioid sparing effect. because they've got two mechanism of actions, like I just said. These have a different pathway effect, so it hits it from different angles, so it helps that pain a little bit more and that inflammation to downregulate. Another thing to remember is they have a ceiling effect. You can't keep taking more and more and more of it. After a certain dose, that's it. You can't take more. It's not going to have more effect. Okay, so bear in mind. What's one of the big issues with NSAIDs, by the way? Yes, gastric ulcers, exactly. Yeah, and it says here most fatalities associated with NSAID use are related to GI bleeds. That's pretty big, right? Also, if you look down here, by the way, the risk of heart attack or strokes, it's talking about NSAIDs. Prescription NSAIDs labels, the risk of heart attack or stroke can occur as early in the first weeks. The more people take an NSAID, the more risk there is of a heart attack. And it says here, patients treated with NSAIDs following a first heart attack are more likely to die within the first year compared with those who are not treated with NSAIDs. Yeah, isn't that? And that's our over-the-counter ibuprofen, right? So please bear that in mind, especially if you work on something like a telemetry floor or something of that nature. If you are working with MI patients, they need to know this, because I bet they don't. Now the docs do, and I'm sure they let them know, but even so, it's our job to make sure we help as well. Let's see. Many of the, what do I need to know? Yeah, please be in mind that aspirin is cardioprotective. And again, box 44.3 says FDA required warnings on all NSAIDs. So bear in mind, NSAIDs, high risk for cardiac events. So they can be fatal, okay? And the other big risk, GI. But you didn't know that. I didn't know that till I started delving into all of this. I was like, huh, who knew about NSAIDs? Did anybody know that? No? I did not know that either till I started reading all this. Yeah. Aspirin, though, one of the side effects of aspirin, tinnitus.
Yeah.
Okay, that's a big one with aspirin. And also bear in mind, remember your patients with the G6PD genetic disorder, they can't take aspirin either. So please be aware of that. If the patient is on aspirin and they start saying, you know, my ears are ringing, they've got aspirin toxicity. Okay, so bear that in mind. Okay. And it talks about that on page 682. It just shows you the toxicity, the mildness, or the different levels of toxicity for that. Oh, don't you love this? Look at this. It's always in these little tiny areas that it gives you the HESI potential exam question, right? In these tiny little boxes. Right here, herbal things that can interact. Well, look, our favorites, not just grapefruit isn't in this one, but our other favorites are in here. Feverview, which I don't ever give to people, but anyway, garlic, ginger, and ginkgo. Now we see that all the time. Doesn't that seem to pop up on our exams a lot? These ones,
Ginkgo,
all right?
Ginkgo is on it.
Ginkgo, feverview, garlic, ginger. It interferes with platelets. Basically, it can make them bleed more. All right?
So you don't want to take away aspirin.
Yeah, so just bear that in mind. It always seems to be these little ones in the tiny boxes that are the ones that come up. And this is why I use the book, because, you know, when I see these things, I'm like, oh my gosh, that's been on a HESI. All right, aspirin at the bottom of 683. Yeah, it's in the little box, table 44.5. And it's just the type of thing, I actually starred it because I'm like, that's the type of thing I think might be on an exam. It just, just doesn't surprise me. All right, let's see, aspirin. Yeah, baby aspirin is the one that we want to use. Really, that strength is as beneficial as the high strength. So you might as well use the lower strength and not risk any toxicity for the patient. And of course, you all know about not using it for children, right? Contraindicated in children with flu-like symptoms. Why? Do we remember why? Anybody? Ray's syndrome. Yep. Okay. Can cause, and actually can cause liver damage and be fatal. So we want to bear that in mind. All right. Toradol or ketorolac. We've moved on from our antibiotics, so it's not up there. Ketorolac. It's a powerful analgesic. Let's see what else I want to. It's a great one because it's synthetic as opposed to an opioid. So it's a great medication to be used. Good for pain management, orthopedic type of injuries and things like that. We tend to give them a shock Toradol. It does say it's only supposed to be for short-term use, up to 5 days. It's not supposed to be for long-term use. All right. And the main thing is the effect on the kidneys and GI, just like the rest of them. Ibuprofen. I think we're pretty familiar with ibuprofen, right? Mm-hmm. So I would suggest you read it though and be aware of it. The COX-2 inhibitors, that's your Celebrex, by the way. There's only one of them now, and this is the big issue with Celebrex. Most of them were taken off the market because of the risk with cardiac events. Yeah. So they took it off the market, even though it's a good medication. It's got a lot of risks to it. Let's see, anything else? Gout. I just want to mention one medication, gout. Basically, gout is the overproduction of uric acid, and it builds up in the body as crystals, specifically in like the legs, in the feet. It causes a lot of pain when patients get a gout exacerbation. And we can give things like allopurinol, which you can see right here. That's the first line therapy to help with gout. We can also tell them as well to reduce certain types of the diet, like liver is high in purines. I don't know a lot of people that eat liver, but there's certain foods that are high in purines. Red wine, port, all of those types of things are high in purines as well. And probably when I look, there'll be some other things as well. Let's see, colchicine. When somebody's having an exacerbation of gout, we give colchicine. It's a very old medication. It works really, really well, but we have to be very careful about the amount of colchicine we can give because the patient can actually get toxic with colchicine, and there isn't an antidote for colchicine poisoning. And that's on page 687. The reason I bring it out is, again, I've seen it on an exam, the actual dose. So sort of a weird dose, and that's why it sticks in my brain. It's a sort of weird, you give like 0.6 milligrams, and you give that one dose, and then they can have 1.2 milligrams. They can only have a total dose of about 3 milligrams. Total dose, that's it. So it's like 3 or 4 pills max. And then they have to stop for a few days, and then they can have more. But you can't give more than 3 milligrams. So I want to say it's something like 0.6, then another 0.6, a total max of 3 milligrams. It talks about it right there on page 687. Some people say 6 milligrams, most people 3 milligrams. So just be aware of that, okay? All right, and let's see. Herbal remedies, for osteoarthritis instead of using these types of things. Talks about it in your book, so might be important. Glucosamine and chondroitin. And of course, it talks about it might have an effect on warfarin and the anticoagulant effect on warfarin. So, let's see. Trying to see if there's anything else I want to bring out to you. There's a, bear in mind on page 686, there's just a few more points and then I'm done, I promise you. I love this very, very detailed information about Ray's syndrome. Gives you a lot of detail as to what the issues are with Ray's syndrome. The types of children that it occurs in are age 4 to 12. Chicken pox. We're not going to give aspirin to kids with chicken pox, all right? And as I say, those with flu, it talks about the ages there. Encephalopathy, renal failure and death are the issues with Ray's syndrome. Okay, so we really, really need to teach families not to do that. Also, if you're going to give your kid the varicella vaccine, can't take aspirin. Don't give them aspirin. Avoid aspirin for several weeks after a child has received the varicella vaccine. Okay. Again, we're talking about chicken pox here. So all of this is really important when it comes to Ray's syndrome and aspirin. I definitely would bear that in mind. And bear in mind as well, NSAIDs with our little old people, right? So they go off and get their big bottle of ibuprofen from Walmart. And they're like, yeah, I like it. 800 milligrams a day, perfect. That's awesome. It's a lot of ibuprofen. And so what's the problem with these little old people? Risk for what? Bleeding. Yeah, absolutely. That's a huge issue, right? Other side effects as well. Cardiovascular, like I've said a couple of times, renal issues as well. And also be aware what happens. We've got our little old people, they've got renal insufficiency already, right? And then we're adding insult to injury by putting a bunch of ibuprofen on top of them. Yes?
Back when I had gallbladder issues, I took Motrin around the clock, and I started like bleeding. It wasn't my menstrual, and I thought I was going through like menopause early or something, but it was from me taking Motrin like every 6 hours.
Wow.
Like for days.
Yeah. Yeah, there you go. Amazing, right?
A lot of the older people like to leave too because it's 12 hours.
Right, but
So they're like every 12 hours they're taking one. I know. I met people like that and they swear.
what dose? Do you know what dose?
My mother-in-law take it every day, like they tell me about over the counter.
Because they
Every day,
don't.
and I try to tell her it's bad, but they do it anyway.
Yeah, well maybe you
Like
can.
the bottle this big.
Yes. See, what did I say? They go to Walmart, they get their massive bottle of ibuprofen. Call it whatever you want. You can call it Aleve, but if you look at it, it's ibuprofen, right? Doesn't matter. It's the same thing. Yeah. So yes, we need to be careful with our older patient with their kidney function and their liver function with these medications, right? Just because it's over the counter and they think because it's over the counter, it's going to be okay. But I think really if ibuprofen had been brought out now, it probably wouldn't be over the counter, quite honestly. Let's see if there's anything else I want to say. Yeah. Just bear in mind that they're at risk for toxicity, the older adult, of course, because they're not able to metabolize as easily as somebody who's younger. Same with all medications, but bear this in mind with these. And I think Are we done? Almost. Making sure they drink lots of fluids. And it just repeats the stuff that I've already talked about again. Okay. I think that's pretty much it. Let's see. Yep, that's all of those. So, good. You turn this off. I'll stop recording.
You gonna post it in the announcement?
Yeah.